I call this meeting to order. Welcome to meeting number 42 of the House of Commons Standing Committee on Health. Today we meet for 2 hours with witnesses in our study of over-the-counter pediatric medication. I see we have a couple of members participating online who are well aware of the procedures and the fact that we are the hybrid format is permitted pursuant to House Order of June 23rd, 2022. We're going to get right into welcoming the witnesses. Today we have a panel in front of us who are quite familiar with the committee and us with them. Dr. Stephen Lucas, Deputy Minister of Health Canada, Dr. Supriya Sharma, Chief Medical Advisor and Senior Medical Advisor in the Health Products and Food Branch, Stefania Trombetti, Assistant Deputy Minister, Regulatory Operations and Enforcement Branch, Lindsay Hollett, Director General, Health Product Compliance, and Dr. Kim Goddard, Director, Health Product Inspection and Licensing Division, Regulatory Operations and Enforcement Branch. Thank you all for being with us here today. I understand Dr. Lucas is going to lead us off. You have up to 5 minutes, Doctor. Welcome to the committee. Thanks for being here. You have the floor.
Thank you, Mr. Chair, and good morning. And thank you for the opportunity to appear before the Standing Committee on Health today and participate in the discussion on the availability of non-prescription analgesics for infants and children. As you noted, I'm joined by a number of colleagues from Health Canada, Dr. Supriya Sharma, Stefania Trombetti, Lindsay Hollett, and Kim Goddard, who will work with me to respond to your questions. Premièrement, je tiens à souligner que
First of all, I would like to indicate that the shortage of pediatric analgesics is a priority for Health Canada and that all our efforts are deployed
in Canada touched by this shortage. We also understand the impact it is having on children in need of these medications and the stress it's created for parents and caregivers. With the time that I have for my opening remarks, I would like to share with the committee a quick snapshot of the work that Health Canada has been undertaking to mitigate the effects of this shortage. Drug shortages are a complex and multifaceted issue, with a range of stakeholders having roles to play. Mitigating and resolving drug shortages require a collective effort of many players. Health Canada's experience in managing shortages, the regulatory tools at its disposal, and well-developed government-to-government networks and stakeholder relationships have provided Canada with a solid foundation to address shortages. In regard to pediatric analgesics, Health Canada has been actively engaging in bringing together manufacturers, distributors, retailers, provinces and territories, children's hospitals, the Canadian Pharmacists Association, industry associations and healthcare practitioners, including the Canadian Pediatric Society, to assess demand, the options for expanding supply, and implementing measures to limit the effects of the shortage. Our engagement has been constant over many months, with daily interactions with key stakeholders over the last number of months. Companies who supply the Canadian market, be they large or small, have ramped up their supply. Some manufacturers are now producing these products at record levels in Canada. However, demand continues to outpace supply. Health Canada is using other tools at its disposal to increase the supply, including facilitating the importation of foreign products. When Health Canada first became aware of supply constraints for these products in the spring, we reached out to the suppliers and made it clear that regulatory flexibilities to permit the exceptional importation of foreign product were available and could be used to increase the supply coming into Canada. With the information available at that time, the mitigation approach adopted by suppliers was to ramp up domestic production. The department continued to engage multiple players in the supply chain over the following months, and by late summer, the unprecedented spike in demand made clear that ramping up production would not be sufficient. Again, the department sought proposals from market authorization holders for the importation and sale of foreign authorized supply. In a statement released yesterday by Health Canada, we advised Canadians that we have secured foreign supply of children's acetaminophen that will be available for sale at retail and in community pharmacies in the coming weeks. The amount to be imported will increase supply available to consumers and will help address the immediate situation. To further increase supply, Health Canada has also approved the exceptional importation of infant and children's ibuprofen and acetaminophen to supply hospitals in Canada. The importation of ibuprofen has occurred and distribution has begun. Each proposal received from a company to import a foreign authorized product undergoes careful review by Health Canada that confirm that the product was manufactured according to comparable standards of safety, quality, and efficacy, as are all drug products approved for use in Canada. Pour l'approvisionnement d'analgésiques pour enfants,
For foreign supply of children's analgesics, in addition to meeting the required safety standards, information related to cautions and warnings, dosing directions, ingredients, and other important details will be made available in both English and French to ensure parents and caregivers clearly understand what medication they are using and how to give it to their children. As foreign product generally does not have important safety information available in both official languages, Health Canada works to ensure this is not an impediment to importation.
involves products at a retail level. This can be done, for example, by providing and visibly posting a QR code, website information, and paper printouts in community pharmacies and retail stores where this safety information can be accessed. Health Canada is continuing to work alongside suppliers to facilitate more product coming into Canada to fill the supply needs, and we know that companies are continuing to produce at record levels to meet the needs of Canadians. In addition, through the exercise of regulatory flexibility, Health Canada has facilitated greater access to these needed medications by temporarily allowing the sale of compounded acetaminophen or ibuprofen without a prescription. Regulations on the safety and quality of these products continue to apply, and this measure will be in place until the shortage is resolved. I will conclude by reaffirming that addressing this issue is a top priority for Health Canada, and that all possible efforts are being made to mitigate the shortage of pediatric analgesics. The health and well-being of infants and children has been and remains our highest priority. Health Canada has been actively engaged since observing early signals of a potential shortage, and we have and will continue to dedicate significant resources to resolving the shortage, and as I noted, have mobilized and convened and worked with all the players involved to address it as quickly as possible and on a sustained basis over many months. We will continue to communicate with Canadians, including through our dedicated pediatric analgesics information on our website. Donc, nous nous réjouissons de prendre part à la
So we look forward to today's discussion, and we will be happy to answer any questions that the committee members may have. Thank you.
Thank you, Dr. Lucas. We're now going to begin with rounds of questions, starting with Ms. Goodridge, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to our witnesses for being here on this critically important issue. I guess I'm going to start out by asking, when did Health Canada become aware of this shortage and the crisis?
Mr. Chair, Health Canada first received reports last spring in April concerning some issues in some provinces, for example, Ontario and Newfoundland. We sought further information, engaged the range of stakeholders, including the manufacturers, market authorization holders, and certainly from that part onwards engaged a group of stakeholders and made clear the opportunity to augment supply through the importation of foreign products.
I don't have much time, so I'm going to ask relatively short questions, and I'm going to ask that you perhaps respect and answer relatively shortly if possible. So I'm the Member of Parliament for Fort McMurray. Fort McMurray Cold Lake up in northern Alberta, we don't really have an option to drive across a border to be able to get these medications, which are in vast supply down in the States. I didn't even know that was an option. I just thought I was a mom going crazy in April when my little guy was teething, and I could not find these products. I thought that it was just a supply chain issue. And I would come to Ontario and I could still find them. And so I wasn't as stressed out as perhaps I could have been, but it was ridiculously stressful. And the last time I've seen the products on the shelves in my community was May. That's terrifying for a community that's 5 hours from a children's hospital. When did you start to procure products from elsewhere?
Mr. Chair, I'll start the response and then ask my colleague Stefania Trombetti to augment it. As I'd indicated, we started at the earliest signs of issues last spring on engaging the industry supplying the Canadian market, asking them to ramp up production, which they've done, and provide the input as well as through retail networks from pharmacists, pediatricians, and others about what was going on. So we have from that time both requested and conveyed the importance of increasing supply through increasing domestic production, as well as the opportunity to import product from the state, from foreign jurisdictions.
Fantastic. So some of the news reports have stated that the first international shipments of acetaminophen and ibuprofen are slated to go to our hospitals. How close were our hospitals to running out of supply?
I'll turn to Stefania.
So we know that hospitals, Mr. Chair, were running very low on supplies, and as we do in shortages all the time, part of the mitigation measures are to manage the supply that already exists, and so they were managing that supply. They did have supply, but obviously these additional supplies were very welcome to those hospitals.
Okay, so in looking at Drug Shortages Canada, I've learned a lot about drugs in the last very short period of time. Not something I thought I would have to do as a brand new mom, but that's the case. I'm seeing that there are shortages of other drugs, such as amoxicillin and erythromycin, and I perhaps have pronounced that wrong, but I think you know which ones I'm talking about. And they're pretty basic antibacterial antibiotics. And so my question becomes, what other pediatric medications are in shortage? What is Health Canada doing to prevent us from having a crisis?
So you're correct. The drugshortagescanada.ca website is a very transparent way to see what drugs are in shortage. I'll put that into perspective. You're correct that there are other pediatric drugs that are currently in shortage. That does not necessarily mean that there will be a stock out. So we see typically at this point, there are about 800 drugs in shortage in Canada. To put that into further perspective, those that reach the level that are national critical, at this point we have 22. So on a regular basis, we do manage these shortages successfully. The other two that you mentioned, so azithromycin, amoxicillin, are two drugs that when we receive signals, we take them seriously. We look to understand what the situation is with the suppliers. What does the supply look like? What does the demand look like? What is the reason for the shortage? What is the anticipated end date of the shortage? And we always look at how can we manage supply that exists and how can we shore up that supply. In some cases, manufacturers are able to ramp up supply or bring in supply that is manufactured in other markets. I'll just speak to one example because you asked about examples. Caffeine citrate, for example, is another drug that you'll see on that list that is currently at a national critical level. It's used to treat infants and newborns with apnea. In that situation, we have been able to understand early in the shortage that's been identified what the supply gaps will be, and to work with manufacturers to make sure that we have supply coming in that will fill those supply gaps before they are even felt.
Okay, so my next question is, why are we seeing this in Canada and we're not seeing it elsewhere in the world? Like, this is an absolute failure from the government leadership, because for months, it was that it wasn't Canada's problem. We haven't seen public information coming out from Government of Canada with public information, even telling parents that they're not going crazy. This is an actual problem until it got brought up in question period, and all of a sudden now Health Canada is responding. But my question is, why did it take that long for us to get any attention? I brought this up in committee in September, and crickets from Health Canada. Crickets.
We're well past time. If you can keep your response short, please.
So the issue of drug shortages is not unique to Canada. Many other countries in the world experience shortages, and like Canada, have mitigation measures that they put in place as soon as they identify signals of shortages. Health Canada works behind the scenes, and many of these shortages will not be felt or seen at the patient level. And so that may be why you haven't heard about it, because they are being managed.
Thank you. Next up, Dr. Pawlowski, please, for 6 minutes.
Well, as you may or may not know, I'm a doctor. I still work a little bit in medicine. Before going into politics, I was an emergency room doctor in Thunder Bay for about 18 years or something. And I got to say, I kind of disagree with you when you say that Canada has a history of managing drug shortages successfully, that we have a foundation for addressing drug shortages. And it didn't start with the Liberal government. I was working in emergency room from, I think, 2003 or 2004 in Canada. And we were constantly in the hospital undergoing shortages, often of important drugs like etomidate, which you need for rapid sequence induction in the emergency room, Levaquin, which was, at times we were out of IV Levaquin, which is the kind of primary go-to drug with community-acquired pneumonia. We were out of bicarbonate, pediatric bicarbonate, which is just baking soda and water. Stemetil, which is and continues to be the best drug, IV, to treat migraines. We haven't been able to get that in Canada for years. This was constantly a source of frustration for me in the emergency room, and I don't blame it all on the Liberal government for sure, or the federal government. The hospital wasn't interested in addressing this issue. They just tell us, well, we're out of the drug. Now, my understanding of the regulatory process, especially for drugs that are off patent, it's rather onerous. There's a lot of hurdles you have to clear. You have to get a drug product license, and you also have to have an establishment license. And whether you get an establishment license, my understanding is in some countries where we have a shared good manufacturing process, that it's easier to import drugs from those countries. But my understanding is I think that especially with drugs that are off patent, the profit margin is fairly small. And now a company, if they're an Indian or Chinese company and they want to get that product into the market in Canada, they have to go through all these hurdles, which are fairly onerous hurdles. And given the profit margin, often for some of these drugs, which this isn't the case for acetaminophen, where there's a big market for it, but a lot of these other drugs, the market's much more limited. So given the profit margin is small, the regulatory process complex, they don't want to do it. And that's why these products aren't getting to the market in Canada. That's certainly my perception as a doctor. I don't know whether that's Health Canada's perception of the problem, but how can we address the problem? Because as an emergency room doctor, I was really friggin' frustrated with constantly having this process with drugs.
Mr. Chair, I would start by just indicating Health Canada has and continues to take the issue of drug shortages very seriously. We have certainly seen over the past decade the challenges increase. The challenges are of a global nature with supply chains. In some cases, the active pharmaceutical ingredient coming from just a single supplier. We've been working domestically, strengthening our capability in Health Canada and Stefania's team and with colleagues here to have a focused organizational unit and task force working to address it. We've also been working globally, and Stefania co-chairs an international group of other regulators looking at this issue. And certainly, as we saw in the pandemic, the importance of supporting domestic biomanufacturing is a critical priority, and one in which the government has invested significantly to attract and support businesses develop manufacturing operations in Canada. We routinely work with and have recently in 2021 updated regulatory authorities to further facilitate addressing drug shortages. My colleagues can speak to that. As Stefania said, at any point in time we could have 10 to 15% of drugs having supply challenges, but work actively with multiple suppliers to avoid, to the greatest extent possible, those having impact at the clinician and importantly at the patient and care provider parent level. We have as well worked to look at novel ways of addressing it, including in the pandemic, establishing a critical drug reserve with the provinces and territories. So we are fully engaged on addressing this and using regulatory flexibilities to help facilitate ensuring Canadians get the supply of drugs they need.
Thank you. Now, having worked in a lot of different developing countries, the issue of drug supplies critical all over the world, and certainly all over the world we're concerned about getting good, cheap medications, but also drugs that are effective. And it's certainly a challenge. So what is Canada doing with other countries in order to have some sort of global approach to the problem, some sort of common standards and some kind of standards that other countries can look to in ensuring that a medication that's being bought and used on patients in those countries as well is actually effective and safe?
So I'll start and then turn to Dr. Sharma and Stefania on this. I'll just note that Canada works through our Global Affairs Canada in supporting increasing access to needed medicines, as was the case and continues to be the case in the pandemic, with access to vaccines, treatments, and diagnostics through organizations like COVAX. In addition, we have extensive regulatory cooperation on a global scale. And to speak to that, first I'll turn to Dr. Sharma.
Thank you, Mr. Chair. So, absolutely. So the manufacture of pharmaceuticals is absolutely global, and it's not unusual to have a pharmaceutical where the active pharmaceutical ingredient comes from one country, the first part of manufacturing happens in another country, maybe packaging and labeling happens in another country before it would come to the country in which it's sold. And that's why it's really important that we have international harmonized standards to make sure that regardless of where those ingredients come from or where the finished drug product comes, that they meet the standards for safety, efficacy, and quality in Canada. And that's the case, no matter where it's manufactured. There's an incredible amount of work internationally that goes on both standards for the places where the manufacturing is happening, so through what we call good manufacturing practices, and that's basically the same everywhere in the world. But as well, there's a lot of work on harmonization of the technical standards of how those medications are looked at. There's a group called the International Conference on Harmonization that involves multiple countries from around the world, along with industry, that puts together those technical standards. So again, we because of the global nature of that, it's really important that we have as much harmonization and reliance on making sure that those medications are safe and effective and high quality.
Thank you, Dr. Sharma. Suite Monsieur Garand pour 6 minutes, s'il vous plaît.
Merci, Monsieur.
Thank you, Mr. Chair, and thank you for everyone for being here today. I would like short answers so that I'm able to understand the situation better. Since last spring, Health Canada has been aware that there would be a shortage of some medication. This has been known, and now you're telling us that there are supply chain issues and that this is something that happens frequently in other countries, etc. I would like for you to name another country in the G20 where today, if I go into a pharmacy, I won't be able to find on the shelves pediatric Tylenol. I want the name of one country today.
Monsieur le Président.
Mr. Chair, I note that the shortage, the medication shortage, is a global issue. There are shortages of several medications in other countries. that are fully stocked in Canada relatively to them. There are other countries where there are shortages of pediatric analgesics, including Germany, the UK, etc. I'll give the floor to my colleague.
There are constraints that we know of in countries like Germany, France, Ireland. You are correct. They're not as felt. The impact isn't as felt as it is here, but there are constraints for sure in other parts of the world. The way shortages... okay.
I'm going to interrupt you because my time is short. Thank you. But it's rare that that civil servants answer so succinctly. Thank you. When I look at the data, it seems to me worse in Canada than other countries. So today, in the G20 countries, what other parliament has to have the Department of Health before a parliamentary commission, and what other G country is in this situation to try to understand the shortages? In the UK, in Germany, are parliamentarians having to question officials at the Department of Health to see what's happening with these drug shortages? Mr. Chair, I'm going to say something, and then I'll give the floor to my colleague, Stephanie. First of all, there are factors unique to Canada. The increase of demand is larger if we compare with other countries. As I said, there are shortages of other medications, such as Adderall. There's an Adderall shortage in the U.S., and we don't have this shortage in Canada right now. So there are challenges, different challenges in each jurisdiction. As I was saying, there are distinct factors in Canada right now, more particularly with regards to demand for products. Yes, I understand, but what is the requirement of Health Canada to communicate? My understanding is that there's been a shortage since the spring. We needed a motion by the Conservatives here for us to be able to find out what is happening. And so we have received no data. And then this week, you're talking about supply and demand. This week, announcements were made on amoxicillin, for example, and if I understand correctly, some manufacturers and people who trade in this created a panic among parents, a panic for several days now. There are huge quantities that were ordered. This creates a panic, and if I'm understanding this as an economist at least, and I contacted people in the industry, is that communication from Health Canada is so bad that people are finding things out at the last minute. They panic, and right now you are part of the problem. You are part of this panic among parents, and you are part of the abnormal increase in demand. This is worsening the shortage. I looked at what the Minister of Health has been saying since the spring. Well, the department also, when they say that I look at what the minister has been saying, he never alerted Canadians or families to this. They were never explained what the processes were. Do you have a job to do to communicate with Canadians? Or do we have to haul you before a committee to get answers? Mr. Chair, first of all, I'd like to say that since the spring, each and every week, and during the last part of the summer, and through the fall, we have daily contact with the other stakeholders, such as pediatricians and hospitals, children's hospitals. So the level of engagement is very high. We have been communicating. What is important is that no, I only have 15 seconds left. You understand that parents are in panic mode right now. Do you understand? It's not because you were good communicators. Mr. Chair, I'll give the floor to Dr. Sharma.
Absolutely, the point is well taken that communications need to be very, very careful when it comes to drug shortages. You don't want to precipitate any panic buying. And what we've seen with the specifically with Tylenol and ibuprofen is that there was some tightness in terms of the supply back in the spring. There was an increase in supply, and manufacturers stepped up to ramp up production. And there was intermittent stockouts in different places, but really it was in August where there was more attention to the issue, where that's when we saw this huge drastic increase in purchasing. So that's when it tripled and quadrupled in August. And again, it was variable across the country, but that's when we really had from the manufacturers, the notification that they were unlikely to meet supply, and then went to, working with looking at alternatives to supply. And that's when a lot of the communication started as well. We worked with the Canadian Pediatric Society to put out advice to patients. We worked with other stakeholders as well. But again, we had seen in August that I think some attention to this and some of the communications around it really did, I think, then encourage people to then go out and potentially stock up, buy more than they needed. And then that's really when we started to see some of that shift in not being able to meet the demand nationally.
Thank you, Dr. Sharma. Mr. Davies, please, for 6 minutes.
Thank you, Mr. Chair. On November 11th, Health Canada announced that special imports of pediatric ibuprofen from the U.S. are awaiting distribution in Canada, and pediatric acetaminophen imports from Australia are imminent. The department didn't disclose how much was expected or how the stock will be divided, but it promised fair distribution of supply across Canada. Can you confirm, please, how many doses of ibuprofen have been imported from the U.S. to date, and how many acetaminophen doses will be imported from Australia?
I'll turn to Stefani and Lindsay Hollett to respond.
Mr. Chair, for the question. So that is accurate in that we were prioritizing supply to hospitals, and we were able to secure supply from 2 jurisdictions. Unfortunately, I'm not able to share the exact quantities, but what I can say around fair and equitable distribution, you've heard a lot this morning on the importance that we've placed on collaboration and a multi-stakeholder approach to this shortage. That is coming to benefit us greatly when we are determining fair and equitable distribution. It will look at things like historical, certainly, but also by having these open communication chains with pediatric hospitals, with provinces and territories, with healthcare professionals, we will have also a very good line of sight on where need is greatest.
Why can't you tell me how many doses have been imported? Do you know and you won't tell us, or you don't know?
So thank you again for the question. We work quite closely with market authorization holders, and I'm sure you can appreciate when we have confidential business information in our possession, then we needed to treat it as such. So quantities have been established, but because of confidential business information, I'm not able to share them.
It's confidential how many doses Canadians can expect to receive of a medicine for their children that there's a shortage of? You won't tell them how many doses you have available?
It's the information of those companies that are importing.
Do you have those doses? Have they been received in Canada?
So as I was saying, we are talking here about 2 different importations. So one importation has arrived in Canada.
That's from the U.S.
That's right.
In Australia, you haven't received. When do you expect to receive Australia?
We expect to receive the Australian product. We expect to receive the Australian product this month. I don't have an exact date, but in the next couple of weeks. And I can also say that to expedite the transport here to Canada, we are using air freight to get it here as quickly as possible.
Well, I would hope so, not boat. Yeah. So given that India and China account for approximately 65% of the world's production of active pharmaceutical ingredients, sometimes called precursors, do disruptions to these supply chains, such as geopolitical tensions or changes in export policies, have an impact on pharmaceutical security in Canada?
Mr. Chair, as we've noted, the challenges with global supply chains and their exacerbation in the pandemic have been well noted and documented. We have worked both with countries that produce those to sustain their import, including for further fabrication in Canada. We've as well worked to...
I just wanted, it was a yes or no question. Do they have an impact?
Yes, they can have an impact.
Okay.
That's why we're working to diversify supply and strengthen manufacturing
Get
in
into what
Canada.
you're doing about it. So a recent article in Policy Options said the following. Drug shortages have been a fact of life in Canada for 10 years now. I think we've heard more than just pediatric pain medication. The causes are many and often opaque. Manufacturing issues are cited most frequently, often stemming from quality issues. And with the COVID-19 pandemic, almost coming up 3 years, the manufacturing supply issues have only multiplied. In fact, manufacturing disruptions now account for 62% of drug shortages, as per a recent Health Canada communique shared with stakeholders. What are you doing to address the long-term structural problem of drug shortages in Canada?
So, Mr. Chair, I'll highlight several dimensions. One of them, as noted, is we have, over the past number of years, built our internal capacity for forecasting and understanding supply and demand, early identification of potential risks and shortages, changing our regulatory instruments to enable foreign importation. In addition, we have been working with regulatory partners to strengthen the diversification of supply chains. And then finally and importantly, the government has invested $2.5 billion to strengthen domestic biomanufacturing.
Both. Where I'm going on that. In terms of, I want to focus my last question on domestic supply. In August 2020, an executive order in the United States directed the U.S. Food and Drug Administration to identify a list of essential medications and produce reliable long-term domestic supply chains for goods essential to public health. What has Canada done the same thing? Is Health Canada taking any steps to securing domestic supply chains of essential medicine in Canada?
So, Mr. Chair, as I noted, the government has invested to strengthen biomanufacturing. A number of critical investments have been made, including in regard to future pandemic preparedness, but more broadly, all components from research through to fill and finish of product. We have a strong generic industry that continues to grow and are working to further strengthen innovator and domestic biomanufacturing throughout the entire chain, and are looking at critical medicines that could be at future risk to make sure that we look at multiple strategies to address and preclude future shortages.
Thank you, Dr. Lucas. Next up, Dr. Ellis, please, for 5 minutes.
Thank you, Chair, and thank you to the witnesses for being here. Certainly, we know this has been a very, very difficult time for Canadian parents. Part of the issue, I think, is transparency. You know, this took 4 months until it began to be addressed. It started in April. You made that very clear. Nothing happened until August. When did the Liberal Minister of Health become involved in all of this?
Mr. Chair, what I would note is, as I indicated in my opening remarks, Health Canada has been engaged since the spring, and we're active since the spring in working with manufacturers, pediatricians, children's hospitals, provinces and territories on identifying the risk and encouraging the increase in domestic production, which has been significant and, as I noted, at record level. As Dr. Sharma noted, demand increased significantly in August, and we further engage and heighten the tempo of work with partners and encourage foreign importation, which is happening.
Through you, Chair, I think to Mr. Lucas, I think clearly I asked when the minister became involved in this.
Mr. Chair, we routinely brief the minister, and at instances where we work to further strengthen communication with the public.
Date would be good. Date would be good.
Mr. Chair, as I said, we routinely brief the minister and make information available to Canadians, both directly through Health Canada, as well as through partner organizations, including the Canadian Pediatrics or Pediatrician Association, as Dr. Sharma noted.
Thank you. Through you, Chair, if I could. We're talking about transparency here, and I'm finding it exceedingly difficult to get a transparent answer. Now we're blaming the parents that we didn't want to talk about this to Canadians because we were concerned the parents might buy some more acetaminophen and ibuprofen. That in my mind would be almost victim blaming. Good communication comes down to saying, hey, what is our plan here? It would occur to me very clearly that A, the minister was not involved in this for a very, very long time, which is shameful, and B, that Health Canada had a very, very poor plan in place here. Not to mention that I would suggest we should have anticipated that there might be a surge in the fall of the year and taken it much more seriously in April. I think that's shameful. Second part of that, through you, Chair, would be I think it's exceedingly important to rebuild the trust of Canadians. Part of that is not standing behind the fact that, we can't share how many doses are coming, when they're going to get here, and when they're going to be distributed. That would be an essential part of the plan of transparency to reassure Canadian parents that you're actually doing something. And to me, standing over there, sitting over there, and continuing to refuse to do that is absolutely unconscionable. So I guess my question would be then, what are you going to do about that? How are you going to reassure Canadian parents that you've actually done something, that these medications that are essential are going to be on the shelves, and that we do have a much bigger and looming problem, which we'll have to bring you back for, because clearly you don't appear to have the competence to do it yourselves, that we're going to have to bring you back for to talk about amoxicillin and azithromycin as we moved into the fall and winter season. So, a big question. Fill your boots.
Mr. Chair, we will respond to the points made, and both by myself and Dr. Sharman, perhaps other witnesses, given the range of points that were made. I would just start by indicating, as I had noted, that Health Canada, from the earliest indication of potential shortages in the spring, actively engaged manufacturers, of which there's about a dozen supporting the Canadian market, provinces and territories, children's hospitals, pharmacies, retail networks, pharmacists, pediatricians. We continued to do that, encouraging through the spring based on our plan to increase domestic supply, which happened and is now at record levels, and have made throughout that the opportunity to import foreign product available as an option, for which we had the regulatory tools, and indeed are now doing just that, supporting the importation of foreign product to address that for Canadians. We have communicated with Canadians. I'll turn to Dr. Sharma to describe that. As I've explained, we have a drug shortages task force in place and a dedicated team, and we work to resolve literally hundreds of drug shortages every year so that there is no impact or visibility to patients. We transparently report it through our drug shortages website and have communicated with the range of stakeholders across the country to address this. So very significant amount of work goes to protect the health and safety of Canadians, and certainly for infants and children's, a very focused effort since the spring. I'll turn to Dr. Sharma now to speak to communication, including that which she's participated in to support information for Canadians, both directly from Health Canada and through key partners, including pediatricians.
Dr. Sharma, we are well past time, so if you could be concise, please do. And if you prefer to augment your answer in writing, that would be fine as well. Go ahead.
Thank you, Mr. Chair. I think first we would say that we feel for parents and caregivers. Being parents of young children is a difficult enough job. To try to figure out how to source medications to treat them for pain or fever is just adding to the stress, and we're obviously dealing with situations with respiratory viruses now, so we understand that that's really challenging. Health Canada's role really is a convening function to bring people together to make sure that we're sharing information. In terms of Health Canada communications, as soon as we got a proposal from manufacturers to allow additional product to come in, and that was approved, we communicated. Before that, we worked through our groups like the Canadian Pediatric Society, like the Pharmacist Association, to figure out what should be communicated to patients and who would be best placed to provide that information. And we were talking about when it's advice to parents about what to do about dosing and alternatives, it really is best placed coming from practitioners and people that are doing the healthcare delivery. So certainly we can provide additional information about the communication that we did in Health Canada, but really it was a focus on what Canadians needed to know and who was best placed to provide that information to help them through this shortage situation.
Thank you, Dr. Sharma. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Thank you all the witnesses for being with us today. I have a question for Dr. Lucas. Dr. Lucas, you said in your statement the increase significantly in demand increased in August. What factors are there? Why did the demand increase in recent months? What factors are contributing to that?
As we've noted, there's a number of factors contributing to it. We have seen a more sustained level of viral infections in children above the normal level, and from both COVID but other respiratory viruses that has increased in the fall with respiratory syncytial virus influenza starting now and COVID as well. Another dimension is as people became more aware, and there was some communication on this in August, as Dr. Sharma noted. There was increased buying that contributed to demand. So a number of factors, but an unusually significant viral infection season impacting children has certainly been a major cause, and one which, as Dr. Sharma noted, we're very focused on addressing, and certainly doing everything we can to support children, infants, and their parents and caregivers.
I'm wondering about the review process for import when medication is coming. Can you comment on the process of reviewing, dosing, ingredients, and caution and warning? What work has been done to improve the use of official languages on pediatric medications bottles?
So I'll turn to Stefania Trombetti and Lindsay Hollett to talk about that process.
So when we receive a proposal to import foreign supply, we always review it very carefully for safety, quality, and efficacy of the drug. And that involves reviewing the instructions for use. So the instructions for use, the dosing, how frequent, understanding the formulation, the ingredients that are used, because although you may have the same active pharmaceutical ingredient, it may be packaged in different at different dosage levels, and the other ingredients that go into making a drug may also be different. So the excipients may include dyes that are not used in the dyes. And in this case, I'm thinking about children's analgesics, cherry flavor, for example, or grape flavor. And so we really need to understand those differences and make it clear what those differences are for parents and caregivers. So they know those differences, they can dose at the appropriate level for the age and weight of their children. And if there are any allergies that their children may have, they're aware of that in advance before administering the drug. So that is the drug itself. The other thing that we look at is what manufacturing conditions were used in the formulation and the manufacturing and fabrication of the drug. And as Dr. Sharma referred to earlier, there is an international standard called Good Manufacturing Practices for Drugs that we adhere to, and that we make sure that any drug that is placed on the market in Canada is produced under those conditions. And that is everything end to end, from how manufacturers are storing the active pharmaceutical ingredients to the training of the employees they have on the production line, how they clean the equipment, the credentials of the quality assurance person who's signing off on the batches before they are released to the market, right down through to the distribution chain, making sure that any requirements related to temperature, for example, are observed and that those drugs are in full compliance with all the requirements needed for the market here. Maybe Lindsay will want to add to that.
Thank you, Mr. Chair, for the question. Nothing to add to what we look at, but I can address your question around official languages. When we are looking at a shortage situation, our number one priority is to make sure that critical safety information gets to all people of Canada in the language of their choice. That is why when we have a shortage situation, the preference, of course, is always to use Canadian authorized product to address the situation, where by law all information will be in English and French. However, when we have to consider foreign product, as Stefania mentioned, through that process, then we look at if the product coming in will not be labeled and contain all the information in both languages, like Canadian product would, how can we still ensure that critical information is available to everyone in the language of their choice, English or French? And so what we do there is look at a myriad of options. If product is going to hospitals, then every unit or every shipment going to a hospital will have information in English and French. In the situation we're talking about here, where there's also product on store shelves, we have multiple options to choose from where we can implement some or all. When you purchase at a store, you can be given bilingual information. There can be signage on the shelf, a barcode or a code to scan, as the Deputy Minister mentioned earlier. Making sure on public-facing websites there's information available in all languages. And when we work with companies, there are 1-800 numbers or helplines, making sure that those are serviced in both official languages.
Thank you, Ms. Hollett. Monsieur Garand pour 2 minutes et demie.
Merci, Monsieur.
2.5 minutes, Mr. Garon. Thank you. My colleague, Dr. Pawlowski, talked about the cost of medication earlier, and I've had exchanges with industry stakeholders, and they say that Canadian regulations with regards to pricing are probably one of the reasons for this shortage, because inventories are low. Maybe I'm mistaken, but over the past few years, we've seen deflation of the cost of medication. Prices have gone down, and in the supply chain, there are distributors who are reselling medication at the same price that they paid, but they're paid with a fixed at a fixed rate. So what we see is that for several years now, there are inventories that are smaller. And so if at some point in time there's an increase in respiratory viruses, if there's a demand shock or panic buying due to bad communication from the Government of Canada, we see a very quick reduction in stock. So what is the responsibility in all of this, especially with regards of inventory of the regulation, of the price regulation system in Canada?
Monsieur le Président.
Mr. Chair, I'd first of all like to say that the key factor that has led to the medication shortage, as I said, were advance. Mr. Chair, I'm sorry. I don't have a lot of time, and my question is not being answered. The role of the price regulation system, that is the question. My first answer is that the cost of medication might be a factor, but the PMPRB in Canada has as a role to ensure that there's no excessive pricing. So the regulation is clear in this case. It's not a general regulation, but they guard against excessive costs. And so this has a direct impact on volume, on medication volume, and medication approved and used in Canada. Thank you.
Please, for 2.5 minutes.
Thank you. Ms. Hollett, I sat on this committee since 2015 and for the entire COVID pandemic. And when we asked for details about the COVID vaccines, the government always claimed commercial reasons for not disclosing information religiously. But one thing they always gave was the numbers. Now, is the reason that I think that when the government wants to release numbers to try to make itself look good, that it's procuring lots of COVID vaccines, then commercial sensitivities doesn't seem to be a problem in terms of releasing numbers of doses. But now, where there's a shortage, all of a sudden the government is claiming commercial sensitivity to not releasing numbers that it had no problem doing for vaccine doses, citing the exact same reason. Can you explain that to me?
Thank you, Mr. Chair, for the question. One thing that I should have added earlier is, while I am not able to share now, work is underway with the entities, the companies that we have been working with and are importing to make the information that is being asked for public in very short order on the Health Canada website, public-facing website. So that the need for that information and the importance of that information has been recognized, and we're very close to being able to publish again in a public forum.
I would say that the customers for these doses are the people of Canada. They're paying for them. And when there's a drug shortage, and particularly for parents over drugs for their children, they have a right to know how many doses are coming, in my opinion. Now, Australia's medicine supply security guarantee requires that Australian medicine manufacturers hold 4 to 6 months of stock of critical medicines, particularly those that have historically experienced shortages, within the country to provide a buffer in the event of global medicine shortages. Do we have the same policy in Canada?
Mr. Chair, what I'd say is, as I've noted, we have a variety of strategies to both mitigate the risk of and address in the event of drug shortages.
Mr. Lucas, really, with respect, I didn't ask what strategies we had. I said, do we have a similar policy?
So what I was working to say, Ministers, we have a variety, or Mr. Chair, we have a variety of tools available now. We continue to look at other strategies, including essential medicines. We established during the pandemic, as has been transparently documented, a critical drug reserve, and are learning the lessons from that as we consider going forward.
Well, you said that hundreds of drug shortages per year are resolved. I mean, that sounds like we've normalized a disaster. It sounds like we're just used to having hundreds of drug shortages every year, and you're claiming success that somehow we can avert disaster in this. Isn't the fundamental problem that Canada does not have a domestic supply of critical medicines, and that's where we need to be addressing our efforts? Not on better reporting of the shortages.
Mr. Chair, I've spoken...
You get the last word, Dr. Lucas. That was the last question. Go ahead.
I've spoken about multiple strategies being undertaken, strengthening our capability, working with global regulators, working with manufacturers, strengthening domestic biomanufacturing. As that strengthens, working to resolve issues domestically, looking at the experience from the pandemic and the critical drug reserve. So we're looking at multiple strategies. And, obviously our goal is to ensure that Canadians have access to the medications they need when they need them, and that they're safe, of high quality, and effective. And we'll continue to work towards that, supporting, in particular in this moment, children and infants and their parents and caregivers to address as quickly as possible and through using every tool possible this current challenge with pediatric analgesics.
Dr. Lucas, and to your team, thank you so much for being here. We have another panel of witnesses that are going to speak to this issue in the second half of the meeting. As always, we appreciate you coming, in this instance on fairly short notice, and the patience that you've exhibited with us on this very difficult issue. Thanks again, colleagues. We're going to suspend for 5 minutes while we bring in the next panel of witnesses. If you want to stretch your legs and get a bite, we stand suspended. I call the meeting back to order. I'd like to welcome our witnesses for the second panel. Just a few comments for the benefit of the new witnesses, specifically Dr. Ahmed, who's participating with us online. Doctor, you have interpretation on your screen. You have the choice at the bottom of either floor, English, or French. For those in the room, of course, you can use the earpiece to select the desired channel. Monsieur Garand, je peux vous confirmer que...
Mr. Garon, I can confirm that Dr. Ahmed was sound checked and the quality of his sound is good. And we did a connection test.
I would now like to welcome our next panel of witnesses de l'Association québécoise de distributeurs en pharmacie, Monsieur Hugues Musso, Directeur Général from Children's Healthcare, Emily Grunwald, President and Chief Executive Officer from the Critical Drugs Coalition, Dr. Said Ahmed, physician appearing by video conference from Vancouver, and from the Food, Health and Consumer Products of Canada, Jerry Harrington, Senior Advisor. Thanks to all. We are going to invite Mr. Musso to begin. You have 5 minutes for your opening statement. Welcome to the committee. Sir, à vous la parole.
Thank you, Mr.
You have the floor. Thank you, ladies and gentlemen, for welcoming me today to discuss an issue as essential as the supply of drugs for children in Quebec in Canada. I'm Hugues Musso. I'm the Executive Director of the Association. I represent the Quebec wholesale drug distributors who make more than 16,000 deliveries each week to all hospitals and pharmacies in the province, in downtown Montreal, Blanc-Sablon, and the Magdalen Islands. We have made the choice that all our fellow citizens should have access to the drugs they need when they need them, no matter where they live. It's not a small decision for a territory with one of the lowest population densities in the world. For almost a year in Quebec, the demand for OTC pediatric pain medications has remained at almost double the historical demand, while the major manufacturers have also managed to double their supply to our distribution centers. The strength of demand is preventing us from replenishing our pharmacy and warehouse shelves. Everything we received is deployed to hospitals and pharmacies. The imports recently confirmed by Health Canada are welcomed, and I want to confirm that the issue of the language of labeling of imported products is a false debate. I'll come back to that, but since the drug supply chain is complex, my objective today is to give you a presentation of its main links and then to conclude with possible solutions. The starting point of the drug chain is the active ingredient factories located mainly in Southeast Asia and Eastern Europe. The chemical compounds from these plants are shipped to drug manufacturers who also package and market the products. The wholesalers I represent buy almost all of the drugs that are manufacturers and sell them to pharmacies and hospitals at the acquisition price. The wholesalers are paid according to a model dictated by the provincial governments, which in Quebec takes the form of a fixed percentage of the list price of each drug. This model is applied consistently regardless of the region of drug distribution, regardless whether the drugs are narcotics stored in a secure vault, refrigerated products, or cytotoxic drugs. In fact, Quebec and Canada can count on a drug supply chain that is among the safest and most efficient in the world. This is perhaps one of the most overlooked strengths of our system. 6 companies operate drug distribution centers in Quebec. Our members are the single most important bulwark against drug shortages. With multi-week inventories, strategic stockpiling, and a keen understanding of market dynamics, our members can continue to meet the needs of Canadians even if a supply disruption occurs upstream. However, this stronghold is now under threat. In recent years, extreme downward pressure on drug prices and a lack of predictability in market conditions have weakened the drug chain, with the direct consequence of increasing the number, frequency, and duration of shortages. According to our calculations, the number of prescription drug shortages in Quebec has quadrupled in 5 years. In addition to the issues of price decreases and lack of predictability, now we have skyrocketing cost of fuel and inflation, as well as the increased regulatory burden. Wholesalers will have no choice but to consider reducing the number of drug inventory weeks and reducing the frequency of deliveries to pharmacies. If the government doesn't act quickly, the reform of the Patented Medicine Prices Review Board and the negotiations of the Pan-Canadian Pharmaceutical Alliance will result in further reductions in the list prices of drugs, thereby exacerbating the problem. Allow me to be very clear. Wholesalers are in favor of lower drug prices if they do not impede supply and innovation. In fact, there's a mechanism already in place across the country called listing agreements, which is a viable alternative to achieve savings while isolating the impact on the drug supply chain and shortages. I'd like to conclude with a few additional observations and suggestions related to the shortage of pediatric analgesics. In our opinion, there are three concrete solutions. 1. Stop successive and unpredictable price decreases by using contractual and financial mechanisms other than list price reductions. 2. Halt the critical erosion of distribution funding and reinvest in our supply chain to enable wholesalers to play their full role in addressing shortages. And 3. Work with wholesalers to establish national strategies for the storage of critical medicines in a logic of optimal inventory management according to product expiration dates. Thank you.
Next, Emily Grunwald, President and CEO of Children's Healthcare Canada. Welcome back to the committee, Ms. Grunwald. You have 5 minutes.
Good afternoon, and thank you for the return invitation. My name is Emily Grunwald. I am the CEO of Children's Healthcare Canada and the Executive Director of the Pediatric Chairs of Canada. Children's Healthcare Canada is a national association. We represent all 16 of Canada's children's hospitals, as well as community hospitals, home care, palliative, rehabilitation centres caring for children and youth. We have a unique systems perspective on the continuum of care for children, a population of 8 million and growing. The Pediatric Chairs of Canada are the 17 department heads of the departments of pediatrics in our medical schools across the country. I'm pleased today to join you to provide input on how the shortages of children's analgesics are impacting the delivery of healthcare within our hospital settings and exacerbating strains on emergency departments and entire hospital systems. It's no secret that a very large number of children across this country are very sick. Whether influenza, RSV, or even COVID-19, parents and caregivers have their hands full. Typically, these respiratory infections can be managed at home with readily available over-the-counter pediatric medications, including acetaminophen and ibuprofen. Of course, we know these products are and have been in short supply for several weeks and months. Parents are struggling to alleviate the symptoms at home and are seeking out the assistance of their primary care teams, community pharmacies, and increasingly emergency departments. From coast to coast, children's hospitals in particular, but also many regional community hospitals are experiencing historic volumes of young patients visiting their emergency departments, in part due to the lack of formulations to treat the symptoms of this perfect storm of respiratory illnesses, which show no sign of abating. Here's what we are seeing and hearing across the country. At the Janeway Children's Hospital in St. John's, Newfoundland, their emergency department occupancy topped 200% over the weekend. Their hospital is operating at over 100% capacity. In Halifax, the IWK Emergency Department and ICU have declared a code census, which for 14 days reflects severe overcapacity. The IWK Emergency Department recently registered 200 patients in one 24-hour period, setting a hospital record. Making matters worse, that same day, the IWK saw their highest ever number of patients triaged as seriously ill, requiring admission. Last week, between 11 and 32 patients left unseen each shift. In Montreal last week, the emergency department at CHU Saint-Justin was operating at 300% occupancy. At Montreal Children's Hospital, 250%. Inpatient occupancy at McMaster Children's Hospital in Hamilton hit 140% on Friday, November the 11th. Yesterday, Sick Kids Hospital reduced surgical activity to focus exclusively on emergency and urgent surgeries to create capacity for critically ill children. Half of the kids in their ICU are on a ventilator. CHEO, our children's hospital down the street in Ottawa, announced last week they have opened a second pediatric intensive care unit to care for the most critically ill children. As of Friday, this new ICU reported 280% occupancy. Ontario has created capacity for most critically ill children by now decanting pediatric patients over the age of 14 to adult facilities. In Edmonton, wait times at Stollery Children's Hospital have reached 20 hours for care. Many of our children's hospitals across the country are now activating emergency operations centers to better manage patient access and flow. These are only a few examples, but the story is consistent. Across the country, we are seeing record numbers of children visiting the emergency department, record numbers of admissions, record acuity of patients being admitted, record waits to be admitted, record wait times for time-sensitive surgical interventions, record staff shortages, and mounting public frustration. Beyond exacerbating challenges within the emergency setting, children's and community hospitals commonly rely on analgesics prior to and post-surgical interventions to manage pain, but also to reduce the use of opioids and reduce the likelihood of developing chronic pain. Some children's hospitals are now evaluating whether or not they can perform essential surgical interventions based on the availability of analgesics to manage patients' care before and after surgery. As many in the room will know, the Canadian Pain Task Force recently published an action plan for pain management in Canada. A foremost goal was to ensure access to appropriate pain care for all Canadians. The report shared 3 important recommendations that are relevant to our discussions today. First, the report shares evidence which reveals treating pain with analgesics is not only the right thing to do, it also spares the use of opioids. From an access perspective, the report underscores the necessity to ensure appropriate pain management for our most vulnerable populations, including children. And lastly, the report speaks to the moral and financial imperative to prioritize the prevention of chronic pain, which is not only disabling for children, but creates long-term health system challenges. I think we can agree that the current situation is both unacceptable and unsustainable. Elongated shortages of essential medicines, whether over-the-counter or prescription, is inexcusable in a country like Canada. While this overnight crisis in pediatrics has been actually decades in the making, there are solutions that will provide much-needed relief, even if just in the short term. I'd be happy to elaborate on some of these ideas during question and answer period. Thank you.
Thank you very much, Ms. Grunwald. Next, from Critical Drugs Coalition, Dr. Said Ahmed, physician. Dr. Ahmed, welcome to the committee. You have the floor.
Yep. Thank you for having me. So, dear honorable members, in the context of the committee's urgent study on the shortage of pediatric acetaminophen formulations, and on behalf of the Critical Drugs Coalition, which is a nonpartisan and grassroots coalition of frontline physicians, pharmacists, academics, and pharmaceutical industry experts, I'm speaking to provide recommendations for how the federal government can improve the resilience and security of Canada's drug supply chain. So I should note that, the Critical Drugs Coalition and myself, we have no conflicts of interest, financial or otherwise. I'm a lecturer with the University of Toronto's Department of Family and Community Medicine, also formerly a rural physician, having worked in remote settings all across Northern Ontario, from remote Indigenous communities in Moose Factory to small but very busy towns, and particularly emergency departments in Kenora. I now work at the Vancouver General Hospital's ICU, as well as at the George Pearson Centre, which is a facility for patients with very complex disabilities. So I have a breadth of experience. I've collated my personal experience from these settings and my colleagues' ongoing experiences with drug shortages. I should add that I did have the pleasure of speaking to this committee in May of 2021 in the context of the critical drug shortages that occurred during the peak of the COVID-19 pandemic. At that time, the Critical Drugs Coalition had made a number of recommendations to secure our drug supply going forward. That included better data on the supply of such drugs, the creation of a critical medicines list, and the stockpiling of said critical medicines in a critical drug reserve, especially in anticipation of our respiratory flu seasons and further waves of COVID-19. So this was all included in a public open letter that we had issued to the Prime Minister in August of 2020. It had been supported and co-signed by multiple national bodies such as the Canadian Medical Association and the Ontario Medical Association. Our asks were very clear at that time. To reiterate, our asks were 3 points: a pan-Canadian critical medications list, which the government commits to ensure are always in stock; public support for a generic critical drugs manufacturer to increase redundancy and capacity for said critical drugs; and then greater transparency, data and communications to and from the governments and the health sector around the critical drug supply. So we did hear in April of 2021 from the minister, and there was an announcement around a critical drug reserve. And then there obviously Health Canada folks have mentioned that there's been billions spent in biomanufacturing. However, my understanding is that the critical drug reserve has now been wound down, and it is unclear to me at this point whether we do have any kind of policy around and framework around strategic reserves of critical drugs. I won't reiterate. I do know that we've spoken at length about the causes of the shortages. I will just mention that a cursory review of the drugshortagescanada.ca website for children's acetaminophen formulations states that the 80 milligram per mil suspension has been short due to manufacturing disruptions. So we've been really relying on the 160 mg per mil suspension. From what I've heard from our industry sources, demand's up by about 400%. And despite the manufacturers having increased their manufacturing by about 200%. So really, this is a perfect storm of supply strain and then domino effects to other drugs. We're hearing about amoxicillin, azithromycin, ibuprofen shortages, and it's really taxing our healthcare system, as we have also heard. We are importing pediatric formulations, and certainly folks have spoken about that. It's just interesting because, the United States has not experienced any significant shortages of acetaminophen, and we've been hearing about people bringing bottles of acetaminophen in their suitcases back, and other sort of stopgaps, going to compounding pharmacies, et cetera, to try to get some specific formulations made. So I do think that while we have a number of there's an urgent importation order or a number of solutions for the crisis at hand, we must commit to addressing the root causes of such shortages going forward. And I'd like to once again reiterate what we said back in May of 2021, that we really need a better data on the supply of such drugs. And so that's, how much drug is inside Canada at one time. That's something we need to know. And where the important components of our drugs are actually made. Right, so that's the first thing when it comes to better data. We need a creation of a critical medicines list. I think people are using the word critical medicines, but what does that actually mean? You look at the UN list of essential medicines, that's thousands of medicines. And so truly we actually need to understand what is a critical medicine, and then have policies such as stockpiling of said critical medicines. And it doesn't necessarily have to be physical stockpiling. It could be other sophisticated strategies such as redundant manufacturing capacity in domestic or friendly countries, manufacturing plants, or strategic reserves of the active pharmaceutical ingredients that create these finished pharmaceutical products. So but there's really 3 points that we're going to continue to drive home. And something has to be done because we are seeing rolling shortages of other drugs. People have mentioned azithromycin, amoxicillin. I really do think that if I were to bring it home, we need to define critical drugs. I would put in a plug for a very sharp colleague of mine, Dr. Meena Tadros here, who is a pharmacist and a researcher at the U of T and the Canadian expert on drug shortages. He's been diligently plugging away on measuring the scope of the problem, submitting lots and lots of grants to define a critical medications list, and extensively collaborating with researchers in the US where there's been a matter of national security for their drug supply. And they actually defined critical inputs, which I'll just end with here. They defined what the critical inputs for hospitals would be very early on and very clearly in the pandemic. And that included things from drugs to PPE to even oxygen. So as I said, something has to be done. We do have a number of points and I'm happy to elaborate.
Thank you, Dr. Ahmed. And finally, Jerry Harrington, Senior Advisor with Food, Health and Consumer Products of Canada. Welcome to the committee, Mr. Harrington. You have the floor.
Merci, Monsieur le Président et membres du comité.
Thank you. I'm Jerry Harrington, a main advisor with Food, Health and Consumer Products.
Companies that manufacture and distribute the vast majority of essential products found in Canadian households, including the children's pain relievers that we're here to talk about today. For Canadian families who've endured more than 2 years of the pandemic with school closures, illness, and ongoing disruptions, the shortage of children's pain relievers has added to their anxiety. And as a parent, I understand and how stressful the situation is. But I would add that the current shortage of these medicines is an unprecedented event in my 30 years in this sector, as is the level of mobilization across the industry to try to address it. The major manufacturers of these medicines planned for higher than normal demand for these products in the 22-23 cough, cold, and flu season. This forecasting was done with various factors considered, such as the severity of the cold flu season in the Southern Hemisphere earlier this year, the prevalence or expected prevalence of COVID in the community as we went into the season, and the state of public health measures in place that might influence the spread of infections. Based on those forecasts, production and allocation for Canada was increased substantially. But the infections came early. By late spring, as you've heard previously today, rates of respiratory infections in children were already far ahead of expectations and out of season, putting pressure on inventories just as they were being replenished. In August, a hospital's decision to require prescriptions for children's acetaminophen that had been compounded in their own pharmacy was widely misreported as applying to all such products being sold in community pharmacies. And this, of course, caused an understandable degree of stockpiling by anxious parents, and demand did indeed spike to 3 or 4 times above normal levels, quite quickly emptying supply chains and store shelves, which in turn spurred more panic buying. Now, this has happened within the context of supply chains already being stressed. Business is still not back to normal in our industry. Our member companies continue to face unprecedented and ongoing supply chain disruptions, including complex factors like transportation disruptions and delays, rising costs, and shortages of inputs and labor. Despite these challenges, the manufacturers of children's pain relievers have already ramped up production to 30 to 40% above historic highs, and plants are operating 24/7 as we speak. Replenishing empty supply chains on the fly is always challenging, but as you know, the number of respiratory and virus cases has continued to climb through the fall, pushing ERs and pediatric ICUs well beyond their capacities, as you've just heard. Manufacturers will continue to work around the clock as long as this demand level continues. It's important to understand that this outbreak of respiratory infections is a global phenomenon. Since late winter, sporadic shortages of these medicines have been reported in France, Ireland, Pakistan, Germany, Malaysia, and Japan. Since this summer, industry has looked for opportunities, in spite of those pressures, to supplement Canadian production and allocations with new allocations from global supplies, but those supplies are tight. As early as this summer, Health Canada was signaling to our members that it was prepared to offer regulatory flexibilities that would allow manufacturers to boost production or imports as long as these did not compromise consumer safety. Those flexibilities permitted 2 proposals for imported products directed to hospitals to be approved last month, as you are all aware. And I'm delighted to note, as more recently, we've had another proposal approved for a shipment of children's acetaminophen intended for community pharmacies within weeks. In all 3 of these cases, the degree of supportive collaboration offered by Health Canada played a critical role, and I want to underline that. In these successful outcomes, I want to emphasize that numerous manufacturers continue to explore opportunities for bolstering supplies and are in regular contact with Health Canada to that end. We believe these efforts will result in a market improvement in access to these medicines in the coming days and weeks, but that said, we still have no clear line of sight to the day when the number of these viral cases begins to normalize and demand for these products returns to something resembling normal. And that remains, above all, the public health issue for all of us to address collaboratively. Thank you, and I look forward to your questions.
Thank you, Mr. Harrington. We're going to begin with rounds of questions now, starting with Mr. Genereux, please, for 6 minutes.
Myself, and I'm going to split with Dr. Ellis. Thank you, Mr. Chair, and thanks to all the witnesses for being here. When we heard from Health Canada, we heard from them that they actually were aware of this issue in the spring. In their mind, it only really became an issue when it was publicized in August, and basically only after we started bringing this up in question period did we actually see any movement from Health Canada publicly addressing any of this issue. And I know as a parent, the worst thing in the world is having a sick kid. And no one wants to bring a sick child to the emergency room just because they have a fever. And yet I'm seeing countless reports of that happening because there is no other option, especially in many of our rural and isolated communities that don't have 24-hour compounding pharmacies, and the families don't have the capacity of seeing this, having this medication on hand. Perhaps to Ms. Grunwald, can you describe how many families you guys are seeing at some of your hospitals that are presenting simply with a fever just to get Tylenol or Advil and going home?
Sure. Every single day now for several weeks, our emergency departments across the country are seeing these unprecedented demands. You heard me speak of capacity well over 100% very consistently from coast to coast. I think that the hard truth is we have an undersized healthcare system to serve a growing number of children and youth in this country. So, the gaps that exist in the community for families to access primary care services, the gaps that we're seeing in community hospitals as a result of some of the challenges they experienced over COVID, losing pediatric beds, losing pediatric highly specialized care providers. We're now seeing the impact of that because families have nowhere else to go. So they are showing up in the emergency departments in unprecedented numbers.
Okay, and that's troubling. And I know, I'm 5 hours away from the closest children's hospital, so it's not even a situation where, you know what, we'll just tough it out. If something were to go wrong in a northern and isolated community, this requires airlifting children. This is an exorbitant amount of cost to provinces. Would you agree that perhaps the drugs, the acetaminophen and Tylenol that has been procured by the government should be prioritized to go into northern, isolated, rural, and Indigenous communities to ensure that the most underserved are having access to this?
I think we need to make sure that every child, youth, and family has access to safe and effective medications for sick children, regardless of where they're located in Canada.
Absolutely, but in the absence of a lack of supply, would you agree that there perhaps is a prioritization that should be placed on having families in isolated, rural, and northern communities?
I think we need to make sure that we have access to these medications in rural communities and retail pharmacies and our community hospitals and our children's hospitals, wherever we're seeing children and youth across the country. This is an essential medicine that every child, youth, and family needs to have access to.
All right, and I'll pass it to Dr. Ellis.
Well, thank you. And through you, Chair, if I might, to Mr. Harrington, very quickly, can you tell us when you were first made aware of this critical shortage of acetaminophen and ibuprofen for children?
The association did not become involved until the summer, but we know that our individual manufacturer members were contacted by Health Canada in advance of that, and there were discussions going on at that point.
Great. Thank you very much for that, sir. And Mr. Chair, if I might move a motion that we've had some discussion with here previously, and I apologize to the witnesses for this, but I think it is critical. And the motion has been sent to the clerk in both official languages. And the motion reads as following, that for the next 12 months, Health Canada table with the committee on a weekly basis the number of infant and children's acetaminophen and ibuprofen doses that arrived in Canada that week, the number of doses anticipated to arrive the following week, and that this information be provided in both official languages, and the clerk post this information on the committee's website immediately.
This is our last round. Like this.
Thank you, Dr. Ellis. The motion is in order, and so the debate is now on the motion. The floor is open. Mr. Vancouverton.
Thank you, Mr. Chair. And first, I think the timing of the motion is it's always up to members when they move motions, but we haven't had an opportunity to ask our witnesses any questions on this side yet. So I would like that opportunity before we suspend, because I think we have to suspend in order to see the motion, to deal with the motion effectively. I haven't seen a copy of it. I think out of respect for the witnesses, I reluctantly would suggest that we adjourn debate if necessary, so that we can have a conversation about that, unless the mover of the motion is willing to allow us to continue the questioning round, so that we can more fully take advantage of the situation today. I think this is a really important conversation that we asked for last week. Ms. Goodridge raised an important motion last week to bring witnesses to our committee, and I have questions for them. So before I make a motion to adjourn debate or even suspend, I think this could have happened in 20 minutes. Thanks.
Dr. Ellis, please.
Thank you, Mr. Chair. And, I think that this is a pretty straightforward motion, and certainly I'm not entirely sure what was added by the actual intervention that just happened. We could vote on this very quickly. Why would we not want to be transparent to Canadians and say, let's post the information and move on? I don't see what's so difficult about that. So let's just do it.
Mr. Doherty. Mr. Doherty, we can't hear you.
His microphone is muted on the source.
It's been suggested that your microphone is muted at the source. You want to try it there now?
Can you hear me now?
We can hear you now. You have the floor.
Mr. Chair, thank you for that, and to our colleagues that are there. Listen, we've heard some staggering testimony today. This is obviously an issue that has gripped our nation. I would say that as long as we have 10 minutes at the end of this session, that we can have a fulsome debate on this. I think all colleagues can see this is a nonpartisan issue. We've got some excellent subject matter experts on all sides of the House that can actually speak to this, and I would agree with our colleagues that if we can agree through you, Mr. Chair, that we'll have at least 10 minutes on the end of this to discuss this motion, I think that we should move forward with that.
Dr. Pelosi.
I concur with that. If you want to postpone the debate and go on with another round of questioning, I'm happy to do that.
Mr. Van Couverden?
I think we should adjourn debate. I think that's the only way to deal with this. We have to deal with it right now.
Are you moving a motion on it?
Yeah.
A motion to adjourn debate is not debatable. All those in favor of adjourning debate on the motion, please raise your right hand. Opposed? The debate on the motion is adjourned. We're going to return to rounds of questions. Next up, Mr. Johari for 6 minutes.
Okay, thank you, Mr. Chair, and welcome to our witnesses. Thank you for your testimony. Some of you are back for the second and third time, so welcome again. I'm going to start with Mr. Harrington, and then I'm going to go to Ms. Grunwald. Mr. Harrington, in your opening remarks, you talked about the fact that the respiratory virus that we see in the children, the number has increased dramatically, as well as it is out of season. Can you expand on that one a bit?
a public health doctor, but what we have seen and what has been reported back to us is that things like the RSV virus was appearing earlier in the season than was expected. What we've also seen is that the flu, the uptick in flu infections was also earlier than expected. And what impact that has is on something called demand shift. So at the time when the industry is trying to rebuild inventories during summer in anticipation of the flu season, inventories are being drained. And that's what landed us in the position.
Thank you. You made another comment which is really concerning, and you said, and I quote, "There's no clear line of sight into when this might end." If I'm paraphrasing, I apologize, but I think it's giving you the genesis. I understand the genesis of what you're trying to say. What indicators are you using to say that there is no clear line of sight?
And that is the rate of infections in children.
Thank you. And I'm now going to go to Mrs. Grunwald. Welcome back to the committee again on a different topic. But I think you're becoming an honorary member of this committee. I want to go back to the driver of the demand, because the previous panel really talked about, we realize there's a shortage, we've addressed that, we are trying to expedite that, and we've looked at domestic, international, and then we looked at the driver of the demand, and now we've heard that the cases has gone up, and also it's become a season. Can you share your point of view? Why is this happening to the children? Around the respiratory virus, and why is it out of season?
My perspective is quite consistent with Mr. Harrington's. What we have also learned from speaking with international experts, particularly those leading children's hospitals in Australia, is their experience largely mirrored what we're seeing now in terms of a larger than predicted number of children becoming infected and requiring hospital-based care or hospital admission. In fact, the experience in Australia was twice as bad as their worst model had predicted. So our concerns are that we have not seen the worst yet, that the peak is still to come. And so that's concerning when we look at the volumes of patients our children's hospitals are experiencing today and thinking about how we would manage additional numbers of very sick children.
So if I'm hearing is we are basically ready to peak, or we're at the early stages of peaking, because with fall and the winter coming, we're tail in the fall and the winter, this thing is going to get worse.
Typically, RSV would peak in January, February timeframes. Typically, our flu virus season would be a little bit later towards the holiday season as well. So we're definitely seeing an early onset of both of these two respiratory illnesses. I'm not confident to say that we're nearing the peak. I don't think we have the data to support that, but I do believe the peak is still to come, and we're already well above capacity in the vast majority of the children's hospitals, and taking urgent or unprecedented measures, including doubling capacity of a pediatric inpatient care unit, or looking at decanting children to adult care hospitals.
Thank you, and thank you for correcting me on a near peak. In your closing remark at the end, you talked about that if given chance, you would be able to elaborate in some of the recommendation. Whatever the rest of time that I have, Mr. Chair, can we allocate to Mr. Grunwald to be able to explain or share with us the recommendations that you have? Thank you.
Sure, and some of them are consistent with what we heard Dr. Ahmed, I believe it was, speak to earlier. So thinking about how do we create a pan-Canadian critical medications list specific for children, thinking about how we coordinate education and communications campaigns for parents and caregivers to help them understand at what point they need to seek out urgent or emergent care, what sort of symptoms they can manage at home safely, and how. Also thinking about how we're creating a communications response for not only our children's hospitals, but also our community hospitals, and those especially in rural, remote communities, as well as for family healthcare teams and pediatricians, so that they have line of sight into where are we today in terms of the shortages, when can we expect additional supply. And then I would say lastly, we really still need a coordinated push on immunizations, generally speaking, whether it's a flu shot campaign, whether it's a COVID-19 booster or original vaccine for children. These are essential measures that we know work. just like we know our masks work. So there's lots of actions that we can take collectively, both at the federal level and provincial and local, and we'd like to see those measures put in place as soon as possible. In the longer term, I think we do need to evaluate the merit of strategic reserves for these essential medications to make sure that we're not caught on our hind feet for shortages like these. And I think we would also support a call from the Canadian Pediatric Society, which would see an expert pediatric pharmacological advisory committee tasked with reviewing these drugs that are in short supply and considering a list of alternative agents.
I'm not sure how much time I have, but I'd like to ask the witnesses to submit formally their recommendations to the committee. Thank you.
Thank you, Mr. Johari. Suite, Monsieur Garon, pour 6 minutes, s'il vous plaît.
Merci.
6 minutes, Mr. Garon. Thank you very much, Mr. Chair. I'm going to begin for a question for Mr. Mousseau. I have an article from the Toronto Star here with me. This was published on November the 9th. It says that the children's Tylenol shortage is worsening and that bilingual labeling is part of the problem. So this seems to be a case of regular racism with regards to Francophone minorities and Quebecers. Can you confirm, because you probably know this better than the journalist who wrote the article, is this a correct analysis? No, that's not the reason. It's probably part of the situations that we are very used to dealing with. Early in the pandemic, when we received the first vaccines, some didn't have bilingual labeling. Same thing with the rapid tests. When we had a shortage of infant formula, we have very simple, we have easy solutions to that. Thank you. Now that I feel better, here is the heart of the issue. You spoke about the cost of medication, the cost that you for supply, and the mechanism that you use, and that how you're paid, and how you can deliver this medication. Over the past few years, and I spoke to the Deputy Minister about this, we've seen deflation of costs. For some distributors, there is less revenue. There's less revenue, but the demand is going up. So this, can you explain to us how regulation, more specifically federal regulation with regards to list price, can play a role in order to deepen shortages? Yes, there's a false belief that with the aging of the population, there's more medication consumption, and there's an increase in profit, but that's not necessarily true. So the model is a percentage of the value of the medication's cost. Here's a concrete example. If we have a medication in Quebec and there's a distribution margin of 6.5% and it costs $50, we have a margin that's reduced because there's a rebate. So it's then 4.37%. So we're making a little over $2 with the PMPRB review. This medication could see the medication go down 10%. That means that we would go from $219 to $197 revenue for the distribution for the same act of stocking it and distributing it. So there's a deflation. We have to see, are we going to lower the inventory levels? Inventory is expensive, so yes, it's an issue. So what you're telling me is that in the regulation of medication costs, it's legitimate. What the federal government is trying to do is to make sure that there's no excessive pricing. But in all of this, at some point, they forgot the fact that it had to be distributed. It's almost as if they didn't think about distribution. Well, I think there's a lack of understanding of the different links in the supply chain. There's a mechanism that allows us to make the effective price paid by either the federal governments or businesses or provincial governments. There is a price that is lower than the list price. So a reform such as the one by the PMPRB will not lead to true savings because the price is already lower than the new list price. So it's a reform that will not produce the required effects, but will have as a direct consequence Have you discussed with Health Canada on this? Are they made aware? Do they have as an objective, or do they have a vision to reform the system? Or is their own solution to import Australian Tylenol? Well, we met with them several times. We're following what the Pharmaceutical Association is doing. They have confidential negotiations, but we will have a lowering of prices. And once again, this will affect our ability to have inventory and to maintain service levels. So yes, it's a problem. And no solution has been adopted by the federal government or the provincial governments. We have discussions on both sides, and it's concerning, because the inventory levels will potentially have to be reviewed given the new situation. It's true for pediatric medication, but for all medication. Thank you. On another subject, so a shortage is possible. I understand that even if we had a different, more efficient regulatory system, it can happen. But now we're in a G7 country where the idea of having a list of critical molecules, we could have some rolling inventory. This is an idea that has been proposed. Does the federal government know this? Since when? For how long does the federal government know that this could be a good idea, and why was this not adopted? When people talk to me about this, it seems not trivial, but something that is altogether possible in a G7 country. Why don't we have any Tempra for children? Well, some provinces have this for pharmacies and hospitals, but it does not exist for communities. And we have proposed it. We put the idea on the table because we can have a list of critical medication that can be maintained in a higher level of inventory, and we can maintain these inventories so there's no loss, so that the expiry dates are respected. So this might be a solution that's viable. It's not the only one. A shortage can happen because there's a supply issue, supply that's going down or demand that's going up, and right now what's happening is that there's an increase in demand. So not all shortages could be avoided, but we would, as a province and as a country, have additional tools to respond to these types of situations and avoid them.
For 6 minutes.
Thank you to all the witnesses for being here. Dr. Ahmed, I've got a couple of short snappers just to establish the context, and I want to dig into some solutions. I want to check my perceptions. Am I correct that Canada has had a long-standing problem with drug shortages?
Correct.
And am I correct that this is a fairly broad and pervasive problem? It's not just a drug here and there, but it extends to literally hundreds of drugs in a given year. Is that correct?
Also correct.
And am I also on the right track if I suggested that Canada's pharmaceutical supply has become overly dependent on foreign imports and global supply chains?
Particularly for IV drugs, which form a bulk of our critical drugs, that's also correct.
Do you know if Canada's domestic production of pharmaceutical drugs has gone up or down, say, in the last 10 or 20 years?
Generally speaking, it has gone down. And then if we dive into the weeds of it, we are quite vulnerable for IV medications, which once again form the bulk of our critical medications.
And my final short snapper, we're not just talking about like this is just an episodic problem right now because of flu season and Tylenol. We're talking about a systemic issue that cuts across antibiotics, pediatric oncology drugs, anesthetics, I mean, across the board. Am I correct in that?
Correct.
In October 2020 in Policy Options, you wrote the following: "We have given less thought to a key policy that could build redundancy in our critical drug supply and even create well-paying jobs for that much-needed COVID-19 economic recovery. That is manufacturing drugs in Canada. Until we domestically produce select critical medications and their precursors, we will not be able to secure our drug supply, and we will be left at the mercy of other countries when the future waves of the pandemic arrive." Could you please outline for us why domestic manufacturing is necessary to ensure pharmaceutical security in Canada?
Absolutely. So I do think that when it comes to critical medications, we're seeing exactly what happens, right? So we're seeing people going to emergency departments to get their hands on pediatric formulations of Tylenol. We're seeing we saw shortages of key anesthetics that I use in the emerge in the ICU. So some kind of redundant capacity, some ability to make critical medications really is a issue of security. I mean, in the US, they actually see it as a matter of national security. And hence, there was an executive order passed during COVID-19 where it was very clearly defined what are those critical medications and other inputs in hospital, and how can we actually use the Defense Manufacturing Act to make them in the United States. So that's how they dealt with it. And, we really don't, I mean, they do have shortages, but it's just been managed much better in that sense.
See, in Australia and the United States are sending a surplus pediatric pain medication, so they clearly have enough for their domestic supply. I just want to ask you quickly, we've already heard that Australia requires manufacturers in Australia to hold a 4 to 6 month stock of critical medicines. Is that something that Canada should do?
I would agree with that, yeah. And as I said earlier, stockpiling, we can be quite sophisticated about it, right? So we have to look at all the inputs. So it's not just the fill and finish of the tablet and the drug itself. There's the active pharmaceutical ingredient, mostly sourced from India and China, that we know about. So oftentimes that's also a rate limiting step in the manufacture of product. So be it a supply of API, active pharmaceutical ingredient, be it actually some kind of manufacturing redundancy, or be it actually true physical stockpiles of certain select critical medications. That's definitely something we need to look into.
Mr. Chair, do I have any time left? Because I'd like to give my last question to Mr. Van Couverden if he...
40 seconds. Mr. Van Couverden.
Hey, thanks, Don. Appreciate that. I won't get a chance to ask any questions.
A minute and 40 seconds.
Oh, wow. Thanks.
Yeah.
There you go, coffee. I just have a really quick question for each. Mr. Musso, you mentioned the PMPRB. These are non-patented drugs that we're investigating today. Does the shortage apply to PMPRB really quickly?
No, it applies. The Pan-Canadian Pharmaceutical Alliance looks at generic drugs.
Okay,
same phenomenon.
I was confused. Thank you. Second, Mr. Harrington, tough situations. It's sometimes tough to recognize when a really severe crisis has been averted. And in this case, I think it's fair to say that, you can't take a win, but we've done a lot. You've done a lot. Your supply chains, and I just want to say that I think it's impossible to claim a win when people are struggling and suffering. But I do recognize that there's been a lot done, and I appreciate that. But could you just speak to what has been done and to the degree to which you've been in touch with the federal government over the last couple of months?
Yeah, the challenge, of course, is when Health Canada communicated very early on that there were open flexibilities for imports, manufacturing, et cetera, was making sure that we were able to channel and connect the manufacturers with Health Canada and identify which kinds of flexibilities would make a difference. So I'll just reiterate what's already been said. So far, that has not been getting over regulatory barriers has not been a significant factor.
Thank you very much for that. And lastly, Ms. Grunwald, thank you for being here. Thank you for your consistent advocacy for kids. I think just two really quick questions. One, do you think it prudent to ensure that incremental supply was sent to hospitals given the enormous surge in hospital visits?
Yes, we were seeing a large number of very sick, very young children who needed that level of care in the hospital, and their supply was critical.
Thank you. And just lastly, we as MPs have the ability to communicate to lots of people. Do you have advice for us on how we can, you mentioned vaccination, it's flu season, we should be making available information to our constituents. Any advice to us as MPs to how to communicate that clearly and in a way that is efficacious for getting more people vaccinated?
I think clear, consistent recommendations from trusted leaders, whether those are healthcare professionals themselves or folks like you, is really important to help parents make those decisions to immunize their children and themselves in a timely fashion. And same with the masking. I think we lead by example.
Thank you, Emily.
Thank you, Mr. Van Couverden and Ms. Grunwald. Colleagues, we have a couple of minutes left. We're going to go back to the Conservatives. Dr. Ellis, knowing that we just have a couple of minutes. Go ahead.
Chair, and I'd like to move that we resume debate on the motion. We move straight to a vote, please, sir.
That's a non-debatable motion that we resume debate on the motion. All those in favor of resuming debate for the minute and a half we have left? Opposed? Okay, I'm going to need you to put up your hands again. All those in favor of resuming debate? I see 6. Okay, opposed? And yeah, okay, so the debate is on the motion for the next minute. Dr. Ellis and Mr. Davies
Chair,
and
can we
Mr.
excuse the
Vancouver.
witnesses?
Dr. Ellis.
Move straight to a vote on the motion.
We can't do that until the speaker's list is exhausted. Mr. Davies.
Well, Mr. Chair, I was just going to suggest that we thank and excuse the witnesses while we debate the motion.
All of the witnesses, thank you so much for being with us. There was a lot of information packed into an hour. We're very grateful for your time and respectful of it, which is why we thank you, and you're welcome to stay, but you're free to leave. Thank you so much. Mr. Vancouverton.
Well, I was going to suggest, sorry.
Is there any further debate on the motion? Dr. Pelosi.
Well, first, we need to see the motion in writing, although I think the government certainly supports transparency. I think in this issue, we've already heard the possibility of contractual obligations. The government is, to some extent, a business, and if there are contractual obligations that affect our ability to meet the requirements under this motion, we want to know about it.
Mr. Vancouverton.
Yeah, I agree with my colleague, and I would note that at the same time, members are saying that there's no transparent information while also quoting the source of the transparent information on drugs on the Drug Shortages Canada website, which is in part a lot of that information comes directly from Health Canada. So, you know, I would like to see this this in writing. I would like to, you know, see. I'm happy to talk about this at another time. We have another meeting this week, but I would move that it's 1 p.m. and we all have other obligations today, and we can talk about this on Thursday when it's in writing, in paper, or perhaps in our inboxes. So I'd move to adjourn.
Is not debatable. All those in favor of adjourning the meeting, please raise your right hand. Opposed? The motion is carried. The meeting is adjourned.